Our next presenter, who is called Doreen Tuhebwe, and she's going to talk about building resilience in epidemic management through health policy and systems research, the case of the 2017 Marburg Virus Disease outbreak in Uganda.
My name is Doreen Tuhebwe, and my presentation is titled Deviation from Expected Actions and Actors During the Response to the 2017 Marburg Virus Disease outbreak in Kwen, Uganda. So just briefly about Marburg, this is a viral hemorrhagic fever. With a case fatality rate of about 50%. Secondary transmission usually occurs when you get in contact with body fluids of an infected person. The control of this viral hemorrhagic fever requires effective mitigation, preparedness, response, and recovery interventions. And this usually draws on multiple actors that have to work interdependently in order for them, across all the phases, in order to control this epidemic. So Uganda has had a total of 4 Marburg virus disease outbreaks since 2007, the most recent one being the one that took place in Kwen district in 2017. This is a map. Kwen is located in the far east Uganda, bordering Kenya. So this is where that outbreak happened. So specifically about this outbreak, it was confirmed on 18th October 2017, and at the point of declaration on 8th December, the outbreak stood at 2 confirmed cases, 1 probable case, and 31 contacts. The 2 probable cases, the 1 probable case and 2 confirmed cases, they all died. So as School of Public Health, we have a training program where we do partner with Ministry of Health to investigate outbreaks. So we worked with the Ministry of Health specifically and other actors to respond to this outbreak. But during our off-field operations, we observed that some actions drew more resources while other equally critical actions drew less. You'd find that there are more people, more partners willing to support surveillance, but maybe fewer willing to do door-to-door sensitization. You'd find some of that, and then we'd also see that during the meetings, there are some contradiction in terms of SOPs that actors have to implement, especially around case management, and that posed a challenge, and you'd find that there had to be negotiations in order to harmonize. So this drew our attention as researchers, and we noted that elsewhere such contradictions can lead to confusion, inaction, and also withdrawal of actors that can result in suboptimal outbreak response. So we do recognize that if we have to involve multiple ministries, departments, and agencies, they should be aware about each other's roles and also have the capacity to fulfill those roles. And that informed our study. And we premised our study around the comprehensive emergency management model. We entered at the response phase, but then we thought we would study this phenomenon across the mitigation, preparedness, response, and recovery phases of Marburg virus disease. Because at each phase, multiple actors are drawn. You will find that at mitigation, it's mostly prevention. Maybe you need wildlife authority to come in and say people should not occupy the caves, while at response, maybe a highly medical model around case management is running. So maybe Ministry of Health and other partners who do the medical model are more involved. So this study, as a bigger project, was funded by SPEED, and it had the bigger goal of contributing to building resilience to Uganda's health system through health system research focusing on epidemics. And however, for this presentation, we'll focus on one phase of the emergency management cycle, that is the response phase, in order for us to draw some lessons for discussion on how actors can collaborate. Specifically, for this study, we describe the ideal network of actors in the response phase of Marburg virus disease outbreak in Uganda. We also describe the observed network of actors that actually took part during the response phase of the 2017 Marburg virus disease outbreak in Uganda, and we explored the compliances and deviations therein within these networks. So in terms of methods, each of the objectives drew different a menu of methods. For example, specifically to describe the ideal network of actors, what we did, we reviewed guidelines and standard operating procedures from Ministry of Health, WHO, and like CDC, all those mandated actors that have guidelines to try and identify which actions should actually be implemented during a response phase of a viral hemorrhagic fever, specifically Marburg virus disease. So when we drew those actions, we would also draw out which actors are mentioned in those documents. And after we summarized the actions and the actors as abstracted from the documents, we presented this list to a panel of subject matter experts to validate these actions through a Delphi survey methodology. So they would say, okay, this action, fine, it is mentioned, but it does not apply to us, or change it, or add this. And then we used social network analysis to visualize the ideal network of actors after that validation. So and to describe the observed network of actors, what we did, we reviewed the meeting minutes of the district task force, the Queen district task force, and the national task force meeting minutes, the meetings that were held during the response phase, to draw out which actions were implemented by the different actors and the actors that implemented those actions. And we further supplemented this with doing about over 25 key informant interviews to identify additional actors, that these key actors we had identified from the response documents, who they worked with and what they did. And in a sense, we drew out a network using social network analysis to visualize the observed network of the actors that actually participated in the 2017 Marburg virus disease outbreak. So, and from the key informant interviews, we were also able to pick up the reasons why some actors don't do what they're expected, and the reasons why, and we also summarized those. So in terms of the results, we found that for the expected actors, or what we'd call the ideal actors, that there are different themes or critical actions around response. Within the documents, about 6 key thematic response critical actions were picked up, but when it came to the observed, what actually happened, there were more actions that came up, which drew even more actors. For example, security was not mentioned mostly in the guidelines, but it came up very strongly within the observed actions, because in this specific outbreak there was community hostility and the security had to come in to protect the responders and etc. So also ecological studies, which usually are maybe preparedness activities, they came in during the response as observed. And this drew different actors across the phases, as you see, with mostly many actors being expected and fewer really showing up in terms of numbers. And to visually show this, we found that the ideal network, as drawn from the guiding documents, there were many more actors within the expected network, but less in the observed. In the ideal, there were about 56 unique actors that were expected, but in the observed, only 47 showed up. So you find that also in terms of importance, while the district rapid response team is core in the ideal network, but in the observed network, the district task force actually as the coordinating agents became core in the observed network. And we also noted that there were some 2 in the observed, some 2 on the far right, some 2 actors who were part of the response, but their role was not clear, and who they were connected with and who they worked with was not clear. So everyone would say, okay, we saw them, but we are not sure what they did. So it means that in terms of collaboration, we all need to understand who is there and what is their role. And also in terms of the reasons why some actors don't do as expected, the reasons vary, in that some unexpected actors actually observed, like some community-based organizations in Queen, they were not expected to come and support the response to MVD, but you find that they were mentioned by the key informant interviews that actually they came and they supported community sensitizations and were really impressed. But then some expected actors, but not observed. I think one that came out strongly was the Office of the Prime Minister. They say we didn't really see them here, and yet they are the people who are in charge of disaster management. So it also came up. And then in terms of the reasons, it could be because of lack of financing, logistical support, and technical capacity. So as we, and these are some of the quotes that we drew from the key informant interviews. Yeah, for example, he says that, oh, Community Cares Uganda, they came and they were really surprised and they helped us in house-to-house sensitization. So really unexpected but observed. So we do conclude that during the 2017 Marburg Virus Disease response in Uganda, fewer than the expected actors were observed. And the reasons vary, but then also more critical actions were observed, more than what is really written within the guiding documents and the SOPs. And some relationships between actors and the bigger response network are not clear, and there's need to interrogate that more and possibly inform improvements. And we do recommend that across all the phases of outbreak management, preparedness, mitigation, preparedness, response, and recovery, critical actions and the responsible actors need to be mapped, known, agreed upon, and their roles actually assigned, so that once we are all deployed during an outbreak, every actor knows their role and they are legitimate because they have been assigned, and then we can contribute to building health system resilience to outbreak diseases in Uganda and beyond. Thank you very much.